Avenue blocks, bundle branch blocks. Associate Professor Dr. Alexey Podcheko. Spring 2015. Learning Objectives. To know ECG signs and causes of ventricular tachycardia. To know EKG signs and causes of 1 SD degree avenue blocks, 2 ND degree avenue blocks, 4 subtypes, 3 RD degree avenue blocks, 2 subtypes. Right bundle branch block, complete left bundle branch block, LBBB. Heart rate generated by synode and ectopic sites, beats per minute. Synode at 60 to 100. Atrial cells at 55 to 60. Avenue node at 45 to 50. Bundle up is at 40, 45, 50. Bundle branches at 40, 45, 50. Purkinje cells at 35 to 40. Ventricular myocardium at 30 to 35. Ventricular tachycardia. A tachycardia arising from a focus situated below the bifurcation of the bundle of is termed ventricular tachycardia, VT. VT is characterized by YQRS complexes of 0.12s or greater, and often much greater, in duration, aka broad complex tachycardia. VT is extremely common, particularly in the setting of acute coronary syndrome, as infarction of myocardial tissue is not generally uniform. At the margins of vascular territories there may be a degree of overlap in blood supply between vessels, and it is possible for strands of cells to survive within the infarcted area. Such a strand of viable tissue has lost much of its cellular contacts due to the death of surrounding tissue, and for this reason depolarization and repolarization properties may differ significantly from unaffected tissue adjacent to the infarct. These are the conditions in which reentrant loops arise, and the commonest mechanism triggering VT is a reentry circuit triggered by a ventricular ectopic. Following an initial brief period of irregularity at the time of onset, the tachyarrhythmia tends to be monotonously regular. When VT arises from a single site in the ventricles and the depolarization wave travels through the chambers in a constant pattern, the QRS complexes are all very similar in morphology. This is termed monomorphic ventricular tachycardia. Definition and classification of VT. Ventricular tachycardia is present when more than 3 consecutive ventricular, broad, complexes occur in sequence at a rate of, or greater than 100 beats per minute, 100 to 250 bpm. Forms of VT. Non-sustained VT, a self-terminating run of VT, less than 30 seconds in duration. Sustained VT, episode of VT greater than 30 seconds in duration, or an episode requiring clinical intervention for termination. Why sometimes it is difficult to differentiate SVT and VT. A. It is possible for a focus situated in the supraventricular region to generate a broad complex tachycardia if conduction of the depolarization wave within the ventricles is abnormal. How to differentiate broad complex SVT and VT? By knowing ECG signs of atrioventricular dissociation, avenue, dissociation specific only for VT. RBBB plus SVT equals broad complex SVT. What is the avenue dissociation? A. When electrical events in the ventricles and atria are occurring independently of one another, this situation is referred to as avenue dissociation. What are the 3 major findings on the ECG consistent with avenue dissociation? Recognition of a normal QRS complex, aka capture beat, in a run of broad complex tachycardia. A fusion QRS complex. P-wave activity fused with components of the broad complex. 1. Recognition of a normal QRS complex, a capture beat, in a run of broad complex tachycardia. In the presence of VT, a capture beat represents a rare P wave which has arrived at the junction at a point in time when the conducting system and ventricles are in a non-refractory state. The associated P wave triggering the capture beat may or may not be visible on the readout. 2. A fusion QRS complex may arise if the synode, uninfluenced by events in the ventricles, fires and depolarization is transmitted into the conducting system just as the ventricular focus discharges. The fusion QRS complex generated will demonstrate features of both sources of ventricular depolarization. Like the QRS complexes of the underlying VT, it is bizarre in morphology but bizarre in a different way. 3. P-wave activity fused with components of the broad complex tachycardia VT. P-waves show no fixed relationship with the QRS complexes, indicating that the atria and ventricles are depolarizing independently of one another. In practice, evidence of avenue dissociation in a broad complex tachycardia strongly favors a diagnosis of VT. Evidence of avenue dissociation is detectable on the ECG in approximately 50% of cases of VT. Some clarifications regarding VT. The heart rate observed in VT is variable but most commonly runs between 140 and 200 bpm. The high rates achieved in this arrhythmia, with impaired ventricular filling, are part of the reason why it is so dangerous. Highly abnormal pattern of ventricular depolarization is also a major contributor to cardiovascular instability in VT. Highly deranged pattern of ventricular depolarization may result in an equally deranged pattern of ventricular myocardial contraction with loss of cardiac output. Ventricular flutter clinical significance. Extreme form of VT with loss of organized electrical activity. Associated with rapid and profound hemodynamic compromise. Usually short-lived due to progression to ventricular fibrillation. As with ventricular fibrillation, rapid initiation of advanced life support is required. How to recognize ventricular flutter. Continuous sine wave. No identifiable P waves, QRS complexes, or T waves. Rate usually greater than 200 beats, minute. The ECG looks identical when viewed upside down. Ventricular flutter. V fibrillation. Ventricular fibrillation, VF, is the most important shockable cardiac arrest rhythm. The ventricles suddenly attempt to contract at rates of up to 500 bpm. This rapid and irregular electrical activity renders the ventricles unable to contract in a synchronized manner, resulting in immediate loss of cardiac output. The heart is no longer an effective pump and is reduced to a quivering mess. Unless advanced life support is rapidly instituted, this rhythm is invariably fatal. Prolonged ventricular fibrillation results in decreasing waveform amplitude, from initial coarse VF to fine VF and ultimately degenerating into asystole due to progressive depletion of myocardial energy stores. ECG findings. Chaotic irregular deflections of varying amplitude. No identifiable P waves, QRS complexes, or T waves. Rate 150 to 500 per minute. Amplitude decreases with duration, coarse VF, greater than fine VF. Atrioventricular block. Dysfunction of the avenue node or diffuse damage to components of the ventricular conducting system can result in a delay or even failure of transmission of atrial depolarization into the ventricular muscle mass. This situation is referred to as atrioventricular or avenue block. Classification of avenue blocks. 3 degrees of avenue block are recognized. First degree. Second degree. Third degree, aka complete. Mobitz type 1. aka Wendenbach. Mobitz type 2. Untypable with. Conduction ratio. 2 to 1. Untypable high grade. With. Conduction ratio. 3 to 1, 4 to 1, etc. First degree heart block. PR interval greater than 200 ms. 5 small squares. P wave before each QRS complex. First degree heart block. Causes. Increased vagal tone. Athletic training. Inferior me. Mitral valve surgery. Myocarditis, for example Lyme disease. Hypokalemia. Avenue nodal blocking drugs, beta blockers, calcium channel blockers, digoxin, amiodarone. May be a normal variant. Clinical significance. Does not cause hemodynamic disturbance. No specific treatment is required. Causes: increased vagal tone, athletic training, inferior me, mitral valve surgery, myocarditis, for example Lyme disease, hypokalemia, avenue nodal blocking drugs, beta blockers, calcium channel blockers, digoxin, amiodarone. May be a normal variant. Clinical significance. Does not cause hemodynamic disturbance. No specific treatment is required. Avenue block, second degree, Mobitz-Eye, Wenckebach phenomenon. Progressive prolongation of the PR interval culminating in a non-conducted P wave. The PR interval is longest immediately before the dropped beat. The PR interval is shortest immediately after the dropped beat. The PP interval remains relatively constant. The greatest increase in PR interval duration is typically between the first and second beats of the cycle. The Wenckebach pattern tends to repeat in P-QRS groups with ratios of 3:2, 4:3 or 5:4. Progressive prolongation of the PR interval culminating in a non-conducted P wave. The PR interval is longest immediately before the dropped beat. The PR interval is shortest immediately after the dropped beat. Other features. The PP interval remains relatively constant. The greatest increase in PR interval duration is typically between the first and second beats of the cycle. The RR interval progressively shortens with each beat of the cycle. The Wenckebach pattern tends to repeat in PQRS groups with ratios of 3:2, 4:3 or 5:4. 5:4. Dropped beat. Avenue block, second degree, Mobitz-Eye, Wenckebach phenomenon. Read the comments to the slide. The first clue to the presence of Wenckebach avenue block on this ECG is the way the QRS complexes cluster into groups, separated by short pauses. This phenomenon usually represents second-degree avenue block or non-conducted POX, occasionally SA exit block. At the end of each group is a non-conducted P wave. The PR interval progressively increases from one complex to the next. The Wenckebach pattern here is repeating in cycles of 5 P waves to 4 QRS complexes, 5:4 conduction ratio. The increase in PR interval from one complex to the next is subtle. However, the difference is more obvious if you compare the first PR interval in the cycle to the last. The PP interval is relatively constant despite the irregularity of the QRS complexes. Avenue block, second degree, Mobitz-Eye. Clinical significance. Mobitz-Eye is usually a benign rhythm, causing minimal hemodynamic disturbance and with low risk of progression to third-degree heart block. Asymptomatic patients do not require treatment. Symptomatic patients usually respond to atropine. Permanent pacing is rarely required. Avenue block, second degree, Mobitz-2. Intermittent non-conducted P waves without progressive prolongation of the PR interval. Compare this to Mobitz-Eye. The PR interval in the conducted beats remains constant. The P waves march through at a constant rate. The RR interval surrounding the dropped beats is an exact multiple of the preceding RR interval, for example double the preceding RR interval for a single dropped beat. Avenue block, second degree, Mobitz-2. While Mobitz-Eye is usually due to a functional suppression of avenue conduction, for example due to drugs, reversible ischemia, Mobitz-2 is more likely to be due to structural damage to the conducting system, for example infarction, fibrosis, necrosis. In 75% of cases, the conduction block is located distal to the bundle of His, producing broad QRS complexes. In 25% of cases, the conduction block is located within the His bundle itself, producing narrow QRS complexes. Causes of Mobitz-2. Anterior me, due to septal infarction with necrosis of the bundle branches. Cardiac surgery, especially surgery occurring close to the septum, for example mitral valve repair. Inflammatory conditions, rheumatic fever, myocarditis, Lyme disease. Hyperkalemia. Drugs, beta blockers, calcium channel blockers, digoxin, amiodarone. Litfl, ECG Library, ECG Basics, Avanublock, 2nd degree, Mobitz 2. Avanublock, 2nd degree, Mobitz 2. Definition: intermittent non-conducted P waves without progressive prolongation of the PR interval. Compare this to Mobitz I. The PR interval in the conducted beats remains constant. The P waves march through at a constant rate. The RR interval surrounding the dropped beats is an exact multiple of the preceding RR interval, for example double the preceding RR interval for a single dropped beat, treble for 2 dropped beats, etc. Example of Mobitz 2. Arrows indicate dropped QRS complexes, i.e. non-conducted P waves. Mechanism: Mobitz 2 is usually due to failure of conduction at the level of the His-Purkinje system, i.e. below the avenue node. While Mobitz I is usually due to a functional suppression of avenue conduction, for example due to drugs, reversible ischemia, Mobitz 2 is more likely to be due to structural damage to the conducting system, for example infarction, fibrosis, necrosis. Patients typically have a pre-existing LBBB or bifascicular block, and the 2nd degree avenue block is produced by intermittent failure of the remaining fascicle, bilateral bundle branch block. In around 75% of cases, the conduction block is located distal to the bundle of His, producing broad QRS complexes. In the remaining 25% of cases, the conduction block is located within the His bundle itself, producing narrow QRS complexes. Unlike Mobitz I, which is produced by progressive fatigue of the avenue nodal cells, Mobitz 2 is an all-or-nothing phenomenon whereby the His-Purkinje cells suddenly and unexpectedly fail to conduct a supraventricular impulse. There may be no pattern to the conduction blockade, or alternatively there may be a fixed relationship between the P waves and QRS complexes, for example 2-to-1 block, 3-to-1 block. Causes of Mobitz 2. Anterior ME, due to septal infarction with necrosis of the bundle branches. Idiopathic fibrosis of the conducting system, Lehneker's or Love's disease. Cardiac surgery, especially surgery occurring close to the septum, for example mitral valve repair. Inflammatory conditions, rheumatic fever, myocarditis, Lyme disease. Autoimmune, SLE, systemic sclerosis. Infiltrative myocardial disease, amyloidosis, hemochromatosis, sarcoidosis. Hyperkalemia. Drugs, beta blockers, calcium channel blockers, digoxin, amiodarone. Clinical significance. Mobitz 2 is much more likely than Mobitz I to be associated with hemodynamic compromise, severe bradycardia and progression to 3rd degree heart block. Onset of hemodynamic instability may be sudden and unexpected, causing syncope, Stokes-Adams attacks, or sudden cardiac death. The risk of asystole is around 35% per year. Mobitz 2 mandates immediate admission for cardiac monitoring, backup temporary pacing and ultimately insertion of a permanent pacemaker. Clinical significance. Mobitz 2 is much more likely than Mobitz I to be associated with hemodynamic compromise, severe bradycardia and progression to 3rd degree heart block. Onset of hemodynamic instability may be sudden and unexpected, causing syncope, Stokes-Adams attacks, or sudden cardiac death. The risk of asystole is around 35% per year. Mobitz 2 mandates immediate admission for cardiac monitoring, backup temporary pacing and ultimately insertion of a permanent pacemaker. Avenue block 2nd degree untypable with conduction ratio 2-to-1 form. 2nd degree heart block with a fixed ratio of P waves, QRS complexes, for example 2-to-1. The atrial rate is approximately 75 bpm. The ventricular rate is approximately 38 bpm. Non-conducted P waves are superimposed on the end of each T wave. The atrial rate is approximately 75 bpm. The ventricular rate is approximately 38 bpm. Non-conducted P waves are superimposed on the end of each T wave. Interpretation, avenue block 2nd degree, untypable high grade with conduction ratio 3-to-1, 3 P waves in 1 QRS complex. Avenue block, 3rd degree, complete heart block. No P waves transmitted to ventricles. Perfusing rhythm is maintained by a junctional, narrow QRS, or ventricular broad QRS, escape rhythm. Patient may suffer ventricular standstill leading to syncope, if self-terminating, or sudden cardiac death, if prolonged. Typically the patient will have severe bradycardia with independent atrial and ventricular rates, i.e. avenue dissociation. Ventricular heart rate between 20 to 40 bpm. Summary: 1st degree heart block. All P waves transmitted to ventricles with prolonged PR interval. 2nd degree heart block. Some P waves not transmitted to ventricles. Mobitz type I, progressive prolongation of PR interval. Mobitz type II, constant PR interval. Untypable, 2:1 conduction ratio, i.e. 2 P wave, 1 QRS complex. High grade, consecutive P waves dropped, at least 2 consecutive P waves fail to conduct to ventricular myocardium. 3rd degree heart block, avenue dissociation. No P waves transmitted to the ventricular myocardium. Bundle branch blocks. Under normal, all regions of the ventricular myocardium are depolarized within 0.12 seconds or 3 small squares. When one of the bundle branches is blocked, one of the ventricles must be depolarized by signal spreading by the direct cell-to-cell contact through myocardium. ECG finding incomplete left bundle branch block, LBBB, or right bundle branch block, RBBB, is prolongation of a QRS complex to or beyond 0.12 s in duration, RBBB, right bundle branch block. The major changes are seen in leads V1, or V2, and V6. 1. In the RBBB, depolarization of the right ventricle is delayed and travels to the chamber by the direct cell-to-cell contacts and produces a wide second R wave in the lead V1 or V2, RSR rabbit ear pattern. 2. Slurred S wave in V6. 3. Overall positive QRS complex in lead V1, a must. 4. SD or T wave changes in right-sided chest leads, electrical phenomenon. Not ischemia, not infarction. Right bundle branch block. RBBB, right bundle branch block. Causes of RBB block. RBBB and the ECG may arise secondary to a chronic increase in right ventricular pressure, for example, in primary pulmonary hypertension or cor pulmonale, or an acute rise in right ventricular pressure in, for example, acute pulmonary embolism. New onset RBBB may be observed in myocardial infarction secondary to obstruction of lead. LBBB, left bundle branch block. 1. QRS duration equal to or greater than 0.12 s2. Broad R waves, small notch or M-shaped, in lead I and V6, or V5, with no Q waves. 3. Broad and deep S waves in the septal leads, V1 or V2. 4. Abnormal repolarization with SD depression or elevation in various leads, electrical phenomenon, not ischemia, not infarction. LBBB, left bundle branch block. No Q waves in V6, I, R wave notch may be small or invisible. Causes of LBB block. The presence of LBBB on an ECG is a highly abnormal finding. Significant damage to the left bundle branch is commonly seen in infarction secondary to obstruction of the left anterior descending artery, and new onset LBBB may be the presenting ECG abnormality in a patient with anterior ME. Damage to the left bundle branch in this situation tends to be permanent following resolution of the acute ME. The chronic ST changes associated with LBBB then make interpretation of the ECG at any subsequent presentations with chest pain difficult. The left bundle branch may also be damaged in diseases causing diffuse damage to the left ventricle, for example, hypertension, myocarditis or cardiomyopathy from whatever cause. In addition, during part of its course, The left bundle branch has a close anatomical relationship with the non-coronary cusp of the aortic valve. Consequently, LBBB is seen in diverse diseases of the aortic valve. Left bundle branch block. Right-sided precordial leads. Left-sided. Various leads.